I'm actually not even sure if I'm ready to start. May I start? Good afternoon, everybody. I'm actually going to leave the official welcome to our esteemed Dean, but I do want to wish all of you a warm welcome. And also just to really recognize Dr. Ngobo, who really put this thing together, and this is sort of his brainchild. The other thing, just to sort of, especially to our students, to make you guys aware, today is actually Physician Assistant Day. So this is really a great opportunity for us to actually be talking about clinical associates. What is exciting for me is that this is really not just thumb-sucking information. This is actual research with respect to clinical associates, not only within the educational space, but also within the professional space. And so we are really excited to actually share with you some of the research that has already been done, keeping in mind that there is still a lot more research that needs to be done on this particular profession in this country, not to mention globally. There's a lot of stuff out there globally, but I think in South Africa, there's still a lot of research that is missing that speaks to South Africa and how we can use clinical associates in our context. And I think that's where we're lacking. We've got a very exciting program. I hope all of you have got the program, but just to put a few housekeeping things for all of our speakers, we would respectfully ask that you limit your presentation to 10 minutes. We have a wonderful young lady who I shall say Askhulume, because I cannot say her name in Spedi, who will be timing you. So please just kind of make sure you pay attention to when your time is up. You're exempted, Prof. Abdiakha, from that. But everybody else, we are going to crack the whip on you. Just before we get started, I think I really would like to ask Dr. Ngobo to also come up here and just give us a nice warm welcome and sort of guide us as to where we're going with this program, as this is his baby. Thank you.
Thank you very much, Sisoge. Good day, everyone. Thank you all for coming. We're already 15 minutes late, so I don't want to waste your time, but just to thank you and say that you are not going to regret coming here. It's going to be a very exciting day. So without wasting time, please allow me to welcome the Dean of the Faculty of Health Sciences to officially invite us and open this very important day to us as clinical associates. Thank you, Prof.
Thank you, Program Director and organizers. I would like to acknowledge the MSc for Health and then also the acting head of Health in Gauteng. They might join soon, but just to acknowledge them in their absence at this stage. Ladies and gentlemen, esteemed colleagues and distinguished guests, I'm Professor Tiaan de Jager, Dean of the Faculty of Health Sciences here at the University of Pretoria. Today we celebrate the remarkable research contribution of clinical associates in the vibrant province of Gauteng. In 2008, South Africa introduced the clinical associates as a dedicated healthcare profession, strategically addressing the critical shortage of healthcare workers, especially doctors. It is noteworthy that Gauteng proudly hosts two of these universities that nurture and train these dedicated healthcare professionals, namely the University of Pretoria and the University of the Witwatersrand. Clinical associates play a pivotal role within Gauteng's dynamic healthcare system, where they predominantly serve in a primary healthcare setting. These include clinics, community health centers, and district hospitals, where their presence is a beacon of hope. helping to alleviate the ever-mounting pressure on our healthcare services. What distinguishes the role of clinical associates in Gauteng is the breadth and depth of their scope of practice. These dedicated professionals, yes, all you around here, are empowered to conduct consultations, order and interpret investigations, diagnose and treat common conditions, perform critical medical procedures, assist in surgeries, educate and empower patients, make informed admissions and referrals, and prescribe essential medicines. Their multifaceted abilities are a true treasure, enriching our healthcare landscape and elevating the quality of care we provide. In the heart of Gauteng, where our healthcare system serves a substantial and diverse population, clinical associates emerge as the true #life changers. So the people from UP, from Health Sciences, will tell you what that means. They offer a promising solution to the persistent shortage of doctors and are instrumental in addressing the formidable quadruple burden of disease that our region grapples with. Yet, we remain acutely aware of the challenges that accompany the profession of clinical associates. These challenges encompass aspects such as the evolving landscape of practice, diverse job opportunities, and avenues of career progression. Rest assured, we are steadfast in our commitment to closely examine these challenges and pave the way for clinical associates to thrive optimally within the healthcare system. Today, as we gather on this 6th of October, we join a global community in recognizing this day as an international acclaimed celebration of clinical associates. This momentous occasion provides us with a unique opportunity not only to acknowledge the tireless contribution of clinical associates, but also to reaffirm our commitment to their ongoing development as they share their research outcomes. Furthermore, we welcome the expansion of clinical associate training. The University of Pretoria's initiative to extend training to primary healthcare facilities and underserved communities aligns seamlessly with our overarching goal of ensuring universal healthcare access to all Gauteng residents. The expansion, along with the invaluable expertise of clinical associates, will enable us to reach and uplift even the most marginalized populations. We encourage a robust collaboration with the government in crafting policy direction that will steer the trajectory of clinical associates, especially in the context of postgraduate qualifications. Such collaboration is essential in ensuring the clinical associates receive the recognition and support they so richly deserve. At UP, we recently introduced the PG DIP in public health. This has grown to the largest cohort globally, also creating opportunities for our BCMPs to further their studies. At yesterday's Senate meeting, the MSc in Community-Orientated Practice was approved. This is creating a pipeline for further development and also strengthen the research associated with our communities. As we embark on this symposium, we hope it will be a source of enlightenment, a catalyst of collaboration, and we encourage meaningful change. Our shared aspiration is to be #LifeChangers, leaving a mark on the lives of individuals and the landscape of healthcare through the knowledge and interventions that emerge from our deliberations. In conclusion, Program Director, let us unite in applause and admiration for the outstanding work of clinical associates in Gauteng and beyond. Together, we can fortify our healthcare system, enhancing its capacity to deliver quality healthcare to every resident. Let us embark on this intellectual journey together, united by the shared passion of research. Thank you.
Thank you, Prof. I'm looking for my co-host, and he's way in the back over there. I can't even see him. Next on our program, we actually had the MEC. Now, we're still anticipating that she will get here, so this is the MEC for Health. So what we would like to do so that we can keep things going is we would like to go ahead and start presenting some of the research that is out there. We will start with something that is very interesting to me, and that is, what is the role of clinical associates in mental health in South Africa? I think it's a very important thing, and I hope that we can see some, enlightening things here. For those of us that are educators, lecturers, please pay attention, because it may mean that we need to tweak our curricula a little bit based upon what it is that we learn here. So, to give a warm welcome to Dr. Sahindra Moodley, who will talk to us about mental task sharing in South Africa, a role for clinical associates.
Good afternoon, everyone. Thank you. Yes, 10 minutes. So the title is the title of one of the papers from the work that we've been doing. But what I'm going to try and do is give an overview of all of the research that we've done thus far in terms of mental health task sharing and clinical associates, which is 3 years of work that we're going to try and get through in 10 minutes. So this is part of my PhD, which is looking at task sharing in mental health service provision, developing a model for clinical associates in South Africa. So there were 3 phases. Phase 1 consisted of a review of the BCMP or BMCP curricula. Phase 2 was assessing the readiness for clinical associate task sharing. And phase 3, which we're currently busy with, is identifying key elements of that task sharing model. So just an introduction in terms of mental health and why did we decide to focus on this? Obviously, I think most of you know that there are alarming levels of mental illness in South Africa. So I'm just quoting one national representative study, which is the National Income Dynamics Study, where they found 29% of respondents screened positive for depression. So we're looking at 1 in 3 people in South Africa that have a mental illness, roughly. And there's supply and distribution issues with the mental health workforce. Very few psychiatrists, psychologists, etc., in many parts of the country, in many provinces, in your rural districts. So we need to see non-specialist health professionals play an increasing role in mental health. And if we look at the global literature, there have been task sharing approaches involving doctors, nurses, and lay workers. Very little about your equivalents in other countries, physician assistants, physician associates, etc. The objectives of our study was to describe the mental health content of the 3 curricula, determine knowledge, attitudes, and practices of clinical associates with respect to management of mental illness, describe the attitudes of mental health managers, doctors, and nurses towards task sharing involving clinical associates, and then to identify key elements of this task sharing model. So phase one was looking at the three curricula at UP, WITS, and Walter Sisulu, collective case study approach, and our study in population involved people involved in the program. So the BCMP coordinators, people working at the sites where clinical associates are attached, as well as student representatives. It was done during COVID, so we used video conferencing, and the interviews were analyzed using Atlas TI. So there were two publications that emerged from phase one. Part of the interview involved asking the participants what they thought the role was, or the role that clinical associates could play. And then we looked at the curriculum specifically, and those are the two papers that emerged. So did people feel that there was a role for clinical associates? I think the answer there was yes. So we called that theme, there's a place for them at the table, place for clinical associates at the table. So there was support for that role. We identified appropriate settings for them to render mental health services. Not surprisingly, it was at primary healthcare level, your PHC facility, PHC clinics, CHC, and district hospitals, and potential mental health tasks. So things that came up were a stabilization of patients in casualty, for example, those with acute emergencies, outpatient follow-up, work in community settings in terms of outreach, adherence to psychiatric medication, etc. There was a feeling that the seat at the table needed to be earned, so there was a need for short courses in mental health to build up on the knowledge that was gained during undergraduate training, and a need for a clinical specialization in mental health. I know some of the colleagues don't like the term specialization, so let's say advanced training in mental health. I'm just providing sort of one table from the paper, which is looking at facility-based mental health training. So all of the programs had clinical associates based at facilities for their mental health rotation. At one university it was 2 weeks, at another either 3 or 4 weeks, and one of the universities was 4 weeks. And in University A, they specifically placed their clinical associates, the BCMP students, at a hospital with a mental health unit. So there was usually a psychiatrist or psychiatric registrar involved in their training. University B was the hospital where they were based for the year, as it was the case in University C. So with University B and C, there was considerable variation in terms of exposure, because it wasn't specifically a mental health unit that they were in. So that was one of the gaps we identified. There were a number of others which are described in the paper. Sorry, where am I looking for time? Okay. Yes, okay. Phase 2 was our CAP survey, which involved clinical associates then already practicing. We conducted this between the 1st of December 2021 and July 2022, and these were clinical associates that had qualified for more than 6 months and were not pursuing medical degrees, or had not already qualified with a medical degree. We used an electronic questionnaire which included the 16-item mental illness clinician attitudes scale, which is a validated tool, and then our other questions underwent expert validation and cognitive interviews, and that's been published in a scientific letter as well. What are some of the key results there? So, hearing from the clinical associates themselves, 98% said that they had received training on management of mental illness in their undergraduate degree. 91.9% said they had received a mental health rotation. Only 10% had had additional mental health training after qualifying. Self-reported mental health knowledge, that differed based on the condition. So the highest rating was for substance use disorders, where almost 70% said their knowledge was good or excellent. The lowest was for attention deficit hyperactivity disorder, which was just under 30%. Only 50% said they were quite or very confident taking a mental health history, and 43.2% quite or very confident doing a mental health examination. Okay. But interestingly enough, the majority of them said their current work actually involved taking a mental health history, and doing a mental health examination. And some indicated they were actually prescribing a psychotropic medication. In terms of their attitudes, the MICA score was, the mean one was 37.55. The higher the score, it's scored out of 96, the higher the score, the more stigmatizing the attitudes. So 37.55 is actually one of the lowest ever scores recorded on the MICA, which suggests that they, among clinical associates, they have very good attitudes in terms of mental illness. 83% of participants were interested in doing mental health work. 67% were interested in specialization in mental health. Okay, so phase 2 also included focus group interviews. I'm still busy with the analysis, but the focus group interviews were conducted in those 4 districts: Sarah Batman, eThekwini, Kasabande, and Dr. Kenneth Kuhunda. This was with clinicians and health managers. The themes that emerged from there, obviously mental health is a major problem being faced by the health services, and they have a number of mental health system challenges, health workforce being probably the main one. Clinical associates do have a role to play in mental health. Obviously, this is a different population from the one we did phase 1 with. So there were a few that were skeptical, but the majority thought that they could play a role in mental health. And there was also a view that this advanced training in mental health is definitely worth considering for clinical associates. Phase 3, which is a Delphi survey involving experts in the field, we're looking at 4 things. What should be included in the undergraduate curriculum? What task clinical associates with undergraduate training should perform? In a hypothetical advanced training course, what should be included? And what tasks should those with the advanced training or specialization do? So that we currently, I think, the second round of the Delphi ends today, and we'll see if there's a third round that's necessary, but those results should also be available quite soon. So conclusion, definitely the undergraduate training in mental health needs to be strengthened. I think one or more of the universities need to think about offering, whether it's a diploma or honors degree in mental health, and we've done all of the baseline work for that. So you're welcome to use that information. And then we need to look at the Mental Health Care Act and the scope of practice of clinical associates. I think there needs a review to enable them to work effectively in mental health. And I think that is it. Just to acknowledge the colleagues that have helped from all of the universities. And thanks. So unfortunately, I can't stay for your question time, but I'll be presenting at our school webinar on the 27th of October, and I'll ask Sanele and Aviwe to share that link, so I'm happy to answer all of the questions then. Two questions. Okay, sure.
We can take just 2 questions. Oh, yeah. Can we please take 2 questions? Any question? Yeah. Thanks, Prof.
Thank you very much.
Yeah.
Am I using a mic or should I?
Yeah.
Thanks very much, Dr. Muli. I appreciated that presentation very much. I was wondering about the sense of identity of or understanding of the identity of the clinical associate as they currently stand by the participants that you engaged with. On the one side, I was wondering as to whether there was any lack of clarity around that. But on the other side, if there wasn't a clear understanding, or rather there might have been a sense of that this was a stem cell of sorts that we can then craft in a certain direction. Were there any positive or negatives around that?
Yeah, so I think it depended on the exposure they've had to clinical associates. Some of these districts, for example, Karsabande, there's a lot of clinical associates there, so they were familiar with the work that's being done. Sarah Bartman, for example, not so much so. Yeah, so I think that really depended on people's exposure with respect to clinical associates in terms of what they were able to do. Generally, where people have worked with clinical associates, it's quite clear that what their scope of practice is, and it's not when they haven't. In terms of your question specifically, I think there was the view, and with mental health, that there was this need for sort of additional training. So you have the core clinical associate to work with. I mean, they've got the clinical skills, but you need to build on that mental health aspect for them to be effective. So whether there was a similar feeling with other specialties, I didn't really ask, but I guess it would be similar, pediatrics, etc. So that was the impression that I got.
I want to ask that based on the findings, we understand that most of the clinical associates have been trained in the tertiary setting. So based on the result, do you think that it will influence the training of clinical associates as far as mental health role are concerned, whether we should push them more into the primary health setting or to the tertiary or both?
Okay, I think that's an interesting question. In the Delphi panel, Delphi survey, that's a specific question that we've asked our experts in terms of at what level of care should they be working based on their undergraduate training. So it's quite clear in round one there was consensus on PHC clinics, community health centers, and district hospitals. So nothing above the district hospitals. With the specialization of the advanced training, it was still the same three that came out. Maybe there were a bit more that felt potentially regional hospitals, but they didn't see a role for them at tertiary level or in your specialized psychiatric hospitals.
Thank you very much, Doc. I'm glad our students are here because now we train them in almost all those different levels of healthcare, from PHC to district, and in fact we even include community, which I think is good. Ladies and gentlemen, now we're going to go to the next phase, but before we go there, I also want to acknowledge the presence of the deputy deans who are here with us today, led by our dean. And I think one of the things that we've noticed, they were quite very excited about the leadership within our faculty, that they are willing to come in full support. Having a dean and deputy deans in one event, it's not common. So it just shows the support that we enjoy in this university. Now I want to welcome on stage Dr. Lowe to come in and share with us. Our students, when they go to their clinics or to do their clinicals, we give them electronic logbooks, and Dr. Lowe is going to share some of the information that we get from that. Don't worry, you won't be penalized for anything that he shares here. Thank you.
Thank you. Thank you, Dr. Ngobo. It's good to be here. So my study is on the e-logbooks that our students fill in as they work in the different facilities where they train. Mostly at primary healthcare level, district hospital level, and a little bit elsewhere. So the core values of our BCMP program is that we train students actually in the place where they're going to work. And we use the early clinical exposure to get them excited and enthusiastic about clinical care. There's an authenticity in learning from a real patient that can't be copied or replicated in the skills lab. And we go for that. We do use the skills lab, but students spend a lot of time with patients. In their second and their third year, it transforms into a longitudinal clerkship, where students would then be at the same facility for the whole year, learning from the same patients under the same staff and becoming accustomed and part of that service. We also use ICT a lot. We use electronic devices to then capture what they do. So this data is from 2022, the whole year, from January to December, what students submitted. There were actually 94 students, but 6 of the students didn't finish the year, various problems, trouble. Part of that, mental health issues. The students could not finish the year. 88 students did complete the whole year, and we present their data now. 46 were second years, 32 were third year students, and they submitted 26,000 patients, or the information of 26,000 patients on our electronic record. 52% of those female, and there you can see the different facilities where they work. On the left-hand side of the screen is the second years, on the right-hand side the third year students, and you'll notice that there's 15 different hospitals or clinical learning centers where they worked. 3 of those have got both second years and third year students. And the average was around 300. Every student, an average 300 patients, a little bit more with the third years, a little bit less with the second years, 292 and 309. And the blue line represents the number of students at that facility. What is interesting here is to see that the facility with the lowest average number of patients per student is actually Osindisweni, who had only 3 students there. Shongwe Hospital has got the highest, and they only had 2 students there. It shows us that it actually depends on the quality of the student, how many patients they logged. It's not whether there are many students or few students. With a lower number of students, you get the outliers then. The population pyramid of those patients, the ages of the patients that they submitted, confirms fairly well to the South African population. There's the gap there. In the earlier ages, we know that these people don't come to hospital, teenagers, and young children are often not sick. We see the difference with the third year students on your right-hand side, that they saw more babies under 5. And that's because they have a specific pediatric rotation. They also have more female patients because they have a specific maternal health rotation. So that's the distribution of the patients, and this also speaks to us that our second year students maybe need more exposure to pediatric patients. That's one of the messages that we get from this graph. The students also log the procedures they do with the patients. They logged, like the second year students logged 11,000 procedures on those patients that they saw. The 20 most common ones, and obviously the students see venipuncture, that's the thing you do all the time. Take blood, putting up drips, those are the 2 commonest. And I think it's good. Students must be excellent in doing this, performing it to the utmost precision with the least discomfort for the patient. And then there's a lot of other different procedures that they do. The blue indicates where they actually performed the procedure, the yellow where they assisted with it, and then there's a gray where they just observed the procedure, which is the minority. So this indicates also the contribution of the students to the service that the service is delivered by the healthcare system. Third year students, similarly, venipuncture was the most common one, with IV line second, but then comes more complicated things, suturing, CTG, ECG. You'll see many different, they assist with a lot of spinal anesthesias, they assist with cesarean sections, and then at the bottom you can see there's a lot of unclassified or other, under other. There's actually 154 different procedures still listed there. So there's quite a wide variety of procedures that students do engage with and learn from. Then if we look at where, the places where the students actually go and learn, we see a preference for the emergency department. I think students get excited, go to the emergency department. Things happen there. You see things, you do things, you get opportunities for procedures. So that's not necessarily a bad thing, but it's noted. We see that the third-year students are more in maternal health due to their maternal health rotation. They're also more in pediatrics because they have a child health rotation, whereas second-year students more time in outpatient department, medical wards, and in the primary healthcare clinics. So we're glad that we see the students going into the primary healthcare clinics, and I think that relates specifically to an elective, which they did in 2022, and that elective was a requirement that they should do it at the primary healthcare at the community level, and then other places. So we can correlate then this to the diagnosis also that the students submit. So we had a system where the students could select on a drop-down list 13 different diagnoses. So we can say it's 13 selected diagnostic categories. They didn't do it for all of their patients. I don't know why. Maybe other patients didn't have any of these 13 conditions, that's fine. But 14,000 such diagnoses were selected amongst 12,000 patients. So some patients had more than one diagnosis. And what's interesting is the top 5 is HIV, hypertension, trauma, pregnancy, diabetes. What is missing here is mental health, and it wasn't an option for them to select. But we'll look at the next slide. What we did then is this is just a comparison where we looked at data from the literature from 2017. Unfortunately, it's old data, but that's what we could find from the Health Systems Trust, the District Health Barometer. How they classified and the number of years of life lost due to mortality in South Africa. And it's interesting how closely it correlates to the data from students, that the patients they see are exactly those same types of conditions. Communicable diseases, maternal health, nutritional causes, 15 or 16% of years of life lost, 15% of what the students see. HIV and TB, around 22, 24%. Injuries quite prominent, and then non-communicable diseases. The most common cause of years of life lost was also the most common conditions that students reported. In this slide, we distributed those according to the 5 categories, or 4 categories, according to which correlates more or less to the quadruple burden of disease, and compare it across the different sites. If we see that all the different learning sites do actually see a lot of trauma, HIV infection, a lot of hypertension, you can see the gray areas all over. What is interesting is that there's some sites where trauma is quite minimal. Pretoria West and KwaMhlanga, almost no trauma cases there. So that's something to look at and to see that can students then rather do a rotation at a different hospital to make sure that they get exposed to sufficient trauma cases as well. So this is the more detailed analysis that one can do. We also did ICPC coding, the International Classification of Primary Care, for diagnostic coding, the diagnosis that the students submitted. And we only coded about 6,500 patients, and those are the top 20 conditions from the coding. And here the mental health do appear. You'll see psychosis, unknown psychosis, 7th from the top, and schizophrenia was just outside the 20 at number 24. So there was some mental health there. But again, this corresponds very well to the quadruple burden of diseases, which you can see trauma 27%, NCDs 17%, and then the others follow. TB and HIV also quite prominent. The lessons learned: students engage with a variety of patients from both genders in a variety of contexts, and we need to look at students having pediatric patients as well, and the variation across the learning sites need to be monitored, adjustments made, like I said, for trauma patients. The disease profile correlates well with the disease profile seen in South African population. Therefore, we say that work-integrated learning should prepare students well to serve the health needs of the South African population. Just acknowledgements from the Disana Consortium, also sponsoring some of the data analysis and the equipment. And thank you to the students for submitting data. Thank you for those who coded. Thank you very much.
Thank you. I just want to make sure that my second year students were paying attention. Did you see when they did the ICPC, musculoskeletal injuries? Because we're busy with musculoskeletal injuries right now. Okay, that was my teacher coming out. I think Dr. Ngobo's got an announcement to make, and then we'll introduce the next person.
Thank you. The MEC is going to arrive in the next 10 minutes from now. Ne? Can I please ask that when she arrives, we can all please stand up as a sign of appreciation just to welcome her. It's so uncommon to have the MEC in such events, so please let us welcome her when she comes. Thanks.
Thank you for that. Just to say, every time I look at the data that Dr. Lowe presented, I'm always in awe. And every time I look at it, every time I engage with the data, I think about how we can tweak what we're currently doing. And I think this is important, and I'm glad that the students are here, because I think this is also a representation of what it is that you're going to see when you start working. So it's important that you really engage with the material. In order to just quickly go through, I want us to welcome our next presenter, who Scott and I go way back, like way back. But most importantly, both of us are actually graduates from the United States, him in one different state and me in another. So we are physician assistants, but I think both of us, I can say, with clear certainty, have a real passion in ensuring that this profession really takes root, not only in South Africa, but actually the African continent. And I think the both of us have worked tirelessly for this, probably Scott more than me, because Scott is Scott. He has got 2 presentations, but I think we're going to break it up because I think the MEC will be here by then. His first one is going to talk about the benefits and limitations of establishing a PA or equivalent program globally. And I think this is really a perfect time for him to be speaking about this, because I keep saying that Scott went on walkabout. He quit his job and just went roaming. And I kept seeing pictures of him all over the place, not only in the African continent, but all over the world. So I think he's got quite a bit of insight to share with us. Without further ado, Scott.
Great, good afternoon to everyone. Sabana, Sambanani. To my UP friends, thank you. To my colleagues, I honor those in the room, the Dean and the Deputy Deans that are here, thank you, and the MEC that's coming. If she comes in the middle, we'll stop my presentation, that's fine. I have 20 minutes to talk for 2 presentations, so I thought I'd give a little more time to the first, it'll be 12 minutes, and then 8 minutes the second, we may stop again for the MEC. Okay, I'm very pleased to present to you the benefits and limitations of establishing the PA and equivalent profession globally. And this was a systematic review and mixed method study that was done in 2022. I have my colleagues here who are from the United States area. You can see many of us are PAs. I'm also a clinical associate. My health professions number is CA000132. 132, yeah. So we have a real problem around the world, and we know this. The population is growing tremendously, and there's a shortage of healthcare providers. In every country around the world is documented. And this is often due to maldistribution as well. People in urban areas are often working, but not in the rural areas. And those in the rural areas are not having access to the healthcare that can be provided. And we also know that there's some gaps in that performance. So we may have health workers, but they may not be trained to a minimum competency level. Education is catching up with this 21st century health science education, where we want to be more competence-based and demonstrate entrustable professional activities for our healthcare workers. And we know around the world underfunding, not just here in South Africa, but in other places occurs. So we really think that PAs and PA equivalents can be a solution to this problem. And when I talk about PAs and PA equivalents, I mean all of us around the world that carry this profession with us. you'll see that we have maybe 1 million of our clinical practitioners around the world. And in the United States, 168,000. There are 17 other countries that use the title PA, Physician Assistant, Physician Associate, and there are 100,000 of them. But really, we're talking about 33 titles around the world that represent us as PA or PA equivalents: clinical associate, clinical officer, medical assistant, medical associate. We have many, many titles that represent us. Research will show that. In the United States, we started in 1964, and really it was to help with the shortage of healthcare workers in places, urban and rural. The United States is a very vast country. We then developed a bachelor program, and the bachelor program has migrated to a master's program. And the literature right now shows very much confusion around us and around global practitioners. And we don't have recognition everywhere, and we don't have the best utilization. And so there's really no international name for us, and therefore we're not always understood. There's no common scope of practice. There's also no movement usually across borders. To come into this country, there was a process for me to be recognized. And also, we really don't have a full inventory of what we are providing for global health needs. So, research is about providing the gaps and filling in. So we wanted to do that. We wanted to do a full inventory of what PAs could do for global healthcare and alleviate needs. And we wanted to look at different aspects of this and really catalog and be able to help promote the utilization throughout the world. Very passionate about this being recognized and spreading in all locations. A systematic literature review was done, and we did this in March to June 2022. We had 6 databases that we looked at. We had multiple titles. I'll show you those just now for search terms. We also simultaneously had a mixed method study, and we interviewed 9 global experts. And we had an extraction tool that we shared across Excel spreadsheets, and we had a blinded review of these to make sure that we were accurately pulling in the right search terms and the right literature according to our inclusion and exclusion criteria. So you can see there we had 23 different search terms, and we had very few limits, and we had quite a bit of inclusion for healthcare providers, being the PA term or the medical assistant term or the clinical associate term. We also included articles that may mention doctor or nurse, but not solely doctor or nurse. It had to have a PA or PA equivalent included. Systematic reviews will show the flow diagram. We started with 818 articles, and we reduced that down to duplications or things that didn't fit our inclusion criteria to 538 sources. We also included looking hand searching of journals to be sure we would find the right articles. Because the terms are so broad, physician assistant doesn't capture all of the articles that are there. We use this definition, and there are very few definitions in literature, and we hope that this one could take root. I'll read it. A PA or equivalent is a clinical practitioner, 2 to 5 years post-secondary education, trained under the medical model, and that's really important. And that we have clinical decision-making abilities. That's a second really important. All right, we're going to pause, and we're welcoming the MEC of Health of Gauteng to our midst. We're so pleased to have you. Thank you, Madame. We're so pleased to have you. Welcome. We are continuing with a discussion around our clinical associates here in South Africa and more broadly our global clinical associates, which have multiple terms, physician assistant or equivalent. And I was just reading that we are providing healthcare within healthcare teams, and our scope includes diagnosis, treatment, therapeutic procedures, performing minor surgeries, prescriptions, as well as working in specialty disciplines. We focus on primary healthcare, and the cataloging will show this coming up. Some photos of the PA Day in 2017. I think you'll see some familiar locations here. And also on the far side is the South African crew, and on the other side is the United States PA crew, and of course in the middle is UP. So our findings, we're looking at geographic areas. Where are we located? We wanted to do a full inventory of this, and we're really proud that we're in all 6 geographic regions and in 62 countries with 5 US territories. And we're operating in all different economies, and we're all in different healthcare needs, as well as different healthcare systems. And then we found evidence of clinics working in urban and rural areas, and we also found us really fulfilling public health needs and We are faced, though, with some challenges and barriers, which we wanted to document to try to have some areas of success. So this slide's really helpful. It pulls together all the titles of us as clinical practitioners around the world. And you'll note the most common one is clinical officer, which is in 26 countries here in Africa. And of course, just above that, clinical associate, also in Malawi. And then the next most common is physician assistant or associate. I mentioned there are 18 countries around the world with our title, but you can see multiple other titles that we have. We are in these 62 countries around the world and in the 5 US territories, and we spread the entire globe. 1 million estimated clinical practitioners around the world. Here you can see a lot of focus is on primary health care and on the rural settings. So these are divided by our 6 geographic regions, and you can see the titles there, initials. And there are some countries that do focus on specialization. In India, they started to help with cardiac surgery. A surgeon came to the US, saw the PA and the potential, brought them back. They started in private hospitals. They've been practicing 30 years. Only last year did the government recognize them. Versus South Africa, of course, where we were promoted by the Minister of Health and the Ministry of Health at the time, and we were supported along the way by the government. So there are different models of how these clinicians start in different countries. We are mostly in developing economies, 70%. So you find 45 countries where we have PAs equivalents, developing countries. Next is our developed countries, but also some countries who are in transition. Really, the primary healthcare needs is primary healthcare area, and there's also a lot of pandemic, of course, with COVID-19, but even earlier, Ebola, and certainly we're familiar in Africa, the really good work in Liberia and Sierra Leone that our clinical officers are doing there and our PAs. Then you can see the different healthcare systems. So we know of the National Health Insurance, which is going to be rolled out here in South Africa. And we have many of our PAs working in that area, 40%. Next is out-of-pocket, which would be familiar in the United States, where it's a pay-for-service or through employee health insurance schemes, or Belveridges or Bismarck, which are examples in England or in Europe areas. Now, in the United States, we're still trying to get recognized. So there's still barriers to us, even though we've been around for 60 years. We're celebrating 60 years next year. We have 50 US states, and not only recently did the last state recognize prescription rights for us. In Canada, 14 provinces, but they're currently only working in 11 of them. They're trying to spread out to those other areas. So even in developed countries, there are barriers that we're learning about how we can mitigate those. Here in Africa, we've been around 1896. Malawi started with medical dressers. Really proud. We're the 3rd region to start this clinical practitioner. You can see that many areas in Africa also do cesarean sections or other surgeries, which is what's really needed on the ground. There's a real movement for global healthcare and global surgery to move out of the tertiary centers and into rural spaces. But there's a limit by recognition, by our laws, and by standardizations. We really need to look to Kenya. Kenya is leading the way. They have their own clinical officers council that regulates them. They're not part of the medical or dental board like us here in South Africa. They provide 80% of the medicine. There are 28,000 clinical officers and 12,000 doctors. Here in South Africa, we're really trying to come together and mobilize, and we've just formed the Clinical Associate National Consortium, or CAN-C. We can see a way forward for clinical associates. And we're so excited that we have PICASO, which is your professional association. We have the South African Union on board. We have our NCAT, which is National Clinical Associate Academic Team on board. And we have clinical associate representatives from each of the areas of practice. And we have the Health Professions Council representative here. And the CAN-C is working for collaborative processes. Because we really find that what happens most is that clinics do well in countries where they're collaborating together. So you can see it was early support that really helped, establishing regulation and laws. We're very fortunate. Our scope of practice was passed in 2016. India still doesn't have their scope of practice yet. So we really recommend from our studies is that we collaborate together. And my students know about GACOPA, and you know about IAPA. So the International Academy of Physician Associate Educators, I'm the president currently, and we also have amongst us Ms. Lambani Tsusetsi, who's our president-elect. We are working to formulate accreditation standards across the globe. We're looking through the LOOP project, which is a curriculum mapping to map every clinical associate project throughout the different countries. We'll be able to have a minimum standard and minimum competencies. We'll be able to propose what would be a traditional scope of practice that can be performed for us. So in conclusion, our studies found that really we are an adaptable clinical practitioner. We are fit for purpose. We're able to move up into areas of medicine that's needed to provide healthcare and increase access around the world. And we really are a solution to public health in multiple countries, 62 countries around the world. And together, we can move forward so that we can really improve the health of our populations within our different countries. I thank you so much for the time. I thank you for the minister being present. I appreciate your attention.
Thank you very much, Scott, for that presentation. I don't think there would have been a better time for the MECs to join than hearing about what is happening globally. It is quite very encouraging to see that this is not just a South African thing, it happens across the world. Honorable MEC, I'm Sanele Ngobo from the University of Pretoria and would like to warmly welcome you. I'm sure the Dean has done a good job of coming in with you. We are very happy with that. I just want to now welcome on stage, and maybe before I do that, let me just also recap that we've had quite a very good presentation from our colleague who presented about mental health. And he touched on quite very important aspects of the role of clinical associates in mental health. And you would agree with me that in Gauteng specifically, because we're here now, there is quite a huge gap in terms of healthcare workers or HRH for health, specifically when we are looking at mental health. And clinical associates, as you see, the majority of those who are here are clinical associates or clinical associate students. There's a huge gap for them in the South African health system. So we were excited to hear that they have a role to play. And Dr. Saindra just took us through the journey from training to practicing in mental health. And I think we need to have discussions with him. So now I'm going to invite the acting HOD to welcome our MEC, and then to introduce our MEC. I'm welcoming on stage Mr. Arnold Malutana. He's going to introduce our MEC. Thank you.
No, good afternoon. Welcome, MEC, the Dean. Before I do the simplest job of just introducing the MEC, I think having sat through a few presentations, I must just reflect. But maybe just to those that don't know, as students, over 12 years ago, in this country, when the concept of mid-level worker training was introduced, the two colleagues that I MC the program were at the cold face of this. Some of us that were wearing different hats were still lean and mean and had hair. It was a concept, it was a very foreign concept. We had very uncomfortable conversation. I walk in here 14 years later and this thing is making so much sense. Well done and congratulations. I just felt it was important. And also, I now understand why Scott is popular. When I said here Scott was introduced, he got the loudest applause. Now I have context. Scott is a well-traveled man, but Scott really represents the profession quite well. Well done and congratulations, and all the best of the profession. My job is very simple, but maybe just to acknowledge all the dignitaries, the dean, the deputy deans. Apparently, they are not always in one room. I learned that. I left academia years ago, so I just learned that the dean and having them in one room, MEC, is quite a privilege. But mine is really just to acknowledge everyone, of course, the program directors, the professors that are in the room, without mentioning anyone specifically. Dr. Moodley for the presentation. I really internalized. I have a lot to ask and I can't wait for that session, issues about scope of practice, prescriber right, level of confidence. It can't be that patients are subjected to practitioner confidence. It must just either, it's no, it's not no. Those are the issues. You also appreciate that I'm wearing a different hat now. And we are sitting with the pandemic of mental health. If you go to, I was quite encouraged that quite a lot of our facilities, the students are using them for clinical learning practices. And so what was being said there, it's like preaching to the converted. If you've been to Calafone, Tembisa, and any of those facilities, number of mental health practitioners that you, patients that you see in an appropriate levels facility, and the need for you to be able to manage and process those patients as quickly as possible. I think it takes us back to the difficult conversation Mechabalala about Professor Mfenya, and I'm not sure if he's still leading that process of finalizing the scope of practice and other related issues. But that's a different topic for another day. Really, we are just here by firstly, one is to say that the MEC and myself here are not here in this room, not by accident of nature. It's by design and it's by intention. That one, for two reasons only. One is we value and we're interested in the research outcome because they influence practice. Practice is the platform we own the society. So what comes out of here influences the work that me and MEC are held accountable for. So we're here not because we don't have anything. It's part of our work to get the information from the science and how that influences policy and practice. That's the first point. The second point is that, of course, today being the 6th of October, being the International Day of Physicians Associate, the MEC will then in detail give us the context of why and why is that important, and as a society and from a policy point of view, where are we moving and why, where is it important and how does it affect you, especially as a student? What does the policy of government influence you in terms of ability to function, practice, but more so, how will potentially remunerate you eventually? That sensitive topic eventually. But without really wasting time and not taking a lot of your time, mine is to introduce the MEC Nkomralo Hoku, a winter baby, and I don't know if that means anything. A member of the Gauteng legislature, the deputy provincial chairperson of the NGO called African National Congress, the MEC for health and wellness, deliberately, health and wellness, and of course, without wasting time and without reading his CV, sake of time, the Orlando Pirates supporter and MEC for health and wellness. MEC Ralohoko, please address us. Thank you so much.
Thank you, Program Acting HOD. That last part, I think you are going to get better scores in the interview in 2 weeks' time. Thank you, Program Directors. Let me greet you, Dr. Sanele Ngobo and Zuki Chabalala, and the Dean of the Faculty of Health Sciences, Professor Tiang Dijang, and Dr. Moodley from the School of Health Science, Systems and Public Health from the Department of Family Medicine, program participants, and Professor Dean, Professor Jane and Rachel Smith, Mr. Scott Smalley, Mr. Arthur Stapelo, and Aviwe Mgobozi. Good afternoon, colleagues. Today's Clinical Associate Research Symposium, graciously hosted by the Faculty of Health Sciences, marks a significant milestone in our ongoing pursuit of excellence in healthcare. This gathering brings together some of the brightest minds and dedicated professionals in our field, all united by a shared commitment and common vision of advancing medical knowledge and patients' care. Clinical Associates plays a very important role in our healthcare ecosystem. Complex medical scenarios, provide critical care, and collaborate seamlessly with multidisciplinary teams is nothing short of extraordinary. As we convene here today, we celebrate the outstanding contributions of clinical associates to the broader medical community. The symposium provides a fertile ground for the cultivation of ideas and the exchange of cutting-edge research findings. The work presented here today has potential to revolutionize the healthcare practices and improve the lives of countless patients. So this forum is a testament to the power of collective knowledge. It's a testament and to the transformative impact that it can have in our field. Program Directors, Gauteng is privileged to host the 2 of the 3 universities that provide the highest level of training for clinical associates. The University of Pretoria and the University of Wits, and the 3rd, Walter Sisulu University, stands in the Eastern Cape. This underscores the Gauteng's important role in advancing the field of clinical associates in our nation. It is with great pride and a sense of achievement that we acknowledge the deepening partnership between the Gauteng Department of Health and Wellness and the esteemed University of Pretoria. I think I've been here now for more than 4 times. It's like I'm staying here. That's why next year I must come to school. Can't just be a visitor in school, I must be in the class. Just a mere month ago, we engaged in a highly fruitful discussion that paved the way for identifying critical areas of collaboration. Notably, one of the most significant focus has been on the comprehensive training and seamless integration of clinical associates into our robust service delivery framework that the government is having. On this momentous occasion, we, the Department of Health and Wellness, stand in unity with the global community in not only recognizing but also supporting the vital contributions of the Clinical Associates Department. We understand the important role that they play in enhancing healthcare delivery, and it is with a solid dedication that we pledge to nurture their professional growth and ensure their continued success. Reflecting on the journey that we have undertaken, we find ourselves marking the 15th year since the inception of Clinical Associates. Introduced in response to the critical shortage of healthcare professionals, particularly doctors, this initiative have proven to be instrumental in bridging gaps in the healthcare provision. So it is worth noting that this endeavor is part of the broader strategy, which includes initiatives like the Nelson Mandela Fidel Castro Medical Program, and task shifting. And these efforts have empowered nurses and pharmacists, broadening their scope of practice to encompass tasks that were historically their domain of doctors. Ladies and gentlemen, at this stage, it is important to acknowledge that South Africa grapples with a quadruple burden of diseases, which is HIV and AIDS, tuberculosis, and non-communicable diseases, and the maternal and child mortality alongside incidents of violence, trauma, accidents, and emergencies. According to the National Development Plan, the ambitious goal of eliminating HIV and AIDS and TB is set for 2030, a mere 7 years from now. Achieving these targets and demands a concerted effort from the healthcare professionals. I was telling Dean when I was apologizing to him that I was stuck in one area next to Vanderbilt. It's a new area, informal settlement, because we were tracing all those that are defaulting now on the TB treatment. But I think it's critical that we do that as government so that we can bring them in the system again, because it will be easier for us to change the scenario that we're having in terms of the numbers if we do that. So clinical associates have proven that to be indispensable assets within the healthcare landscape, particularly in primary healthcare settings such as clinics, community healthcare centers, and district hospitals. Their contribution have been proven and have been felt keenly as dependable members of their clinical team, taking on responsibilities for case management across the levels of care. Their role is important in alleviating the strain on healthcare services during the critical time. In essence, clinical associations are integral in the transformative journey of our healthcare system. Their proficiency and dedication are instrumental in ensuring that we not only meet our targets in disease eradication, but also pave the way for a more inclusive, more accessible, and robust healthcare framework. The role and capabilities of clinical associates hold exceptional significance as they are proficient in conducting consultations, ordering and interpreting investigations, diagnosing common conditions and performing procedures, assisting in surgery and educating the patients. So these competencies are very important in addressing critical issues within the current Gauteng health system. These challenges encompass the need for an adequate human resource for health in the public sector, the imperative of the establishing sustainably and high-quality healthcare infrastructure that can grow in tandem with the population and disease burden, as well as necessity to mitigate medical legal claims. Furthermore, the integration and application of innovative technologies such as artificial intelligence and the Internet of Change in the healthcare, aligned with the principles of 4th IR, require the expertise of clinical associates. Additionally, these professionals contribute significantly to the training of specialist clinicians, doctors, nurses, and hopefully future clinical associates. program directors, in the context of specialist training, recruitment and the utilization of clinical associates, there is a pressing need for the clarity for those of us working in the service delivery and policy implementation sphere. The intricacies of the job specifications, scope of practice, and the career progression of clinical associates often present challenges in terms of appointment, appropriation of remuneration, and establishment of clear path for their advancement and specialization within the healthcare system and public administration. The ongoing policy reviews and regulatory discussions concerning clinical associates necessitate our active and innovative participation. Meanwhile, both the Gauteng Department of Health and our universities must do what is within our capacity while awaiting policy and regulatory reforms. We are fortunate that we have extensive clinical training platforms in Gauteng. So we commend the University of Pretoria for their innovative expansion of training platforms, extending all the way to primary healthcare facilities and community levels. This aligns perfectly within the current administration's priority of enhancing service delivery in the townships, in the informal settlement, in the hostels and hostel communities. So I want to extend my best wishes for the fruitful deliberations on topics including possible mental health task sharing, lessons learned from the clinical associate student training, the students' inavailable insights on enhancing their learning experiences, and charting a way forward course for the benchmarking as we benchmark ourselves against the achievements of the clinical associates and equivalent health professionals globally. Thank you, program directors.
Thank you, MEC. I'm actually excited to hear some of the words that you spoke, and I'm really hoping that we can actually form a partnership. We're about to go to a small break. But before we do, I actually want to share a story, and this is really for the students, so please indulge me a little bit. Number one, I would like to actually recognize Professor Hugo. Nobody's actually called you out here. But Professor Hugo, I think we call him the grandfather of the Clinical Associate Program. You know, he's been our leader here and continues to be, I think, in my opinion, a visionary for where we should go. For instance, as you mentioned, MEC, one of the clinical platforms that we've actually started using as a training platform for our students is a primary healthcare service. And I was talking to a now clinical associate who specializes in diabetes. And one of the things that she had said, and this is directly to the students, is that the nurses actually have a lot to teach the clinical associates. And I think sometimes we forget about that. And I think sometimes as clinical associates, our own egos get in the way of us actually learning and finding our way within this fraternity of health. Because I think it's not just about policies and regulations, but I do believe that us as clinical associates must also be at the table so that we can guide you. Because remember, we work in those institutions. Some of us teach, and therefore we have a vision for the clinical associates. And so as we develop these policies and these regulations, I think it is important that we have a seat at the table, because I think then it becomes more fruitful. I think in the beginning we did have this where we were very front and center, but that sort of engagement and that collaboration has sort of slipped away. And I do believe this is really the right time for it to come back again. I also want to say, while you are busy recognizing Sanel and I, for one, am really ready to hand over the baton to the so many young people here to take over the leadership. So thank you for your words. I really do appreciate them. My mother did tell me when I first moved here, because I trained in the United States, and I wanted to do things with the clinical associates. She said, Ewen, before you do that, what do you know about the health system in South Africa? She said, start there. So before, I actually had to learn how the system works so that I could marry what I knew about healthcare delivery with what the needs were for South Africa. So I'm really excited that we're in this place. We are going for a small break, is that right? Or are we doing Q&A first? Small break. We have nummies, we have food. Yeah, that's why we wanted you guys to RSVP. It wasn't just attendance. No, I'm going to let Sanele do this. So he keeps surprising me with what is part of this program. He's going to tell us how long the break is. Like I said, I'm just here for the ride.
Thank you, Suzuki. Honorable MEC, when you come here, you can't go back empty-handed. So we have something for you and the acting HOD. If you can please just come forward to receive a token of appreciation. Indeed, we were with the MEC even last week. We were together here at the University of Pretoria in the Tshwane conference. So can I please welcome the MEC? And while she's coming on stage, I think we can give her the title which used to belong to Umaga Sezuki, Umantos Shabalala Msimang, who was the mother of the profession. And now the MEC is becoming the mother of this profession of clinical associates for her support. Colleagues, we are now going to break for 30 minutes and then we're going to come back after that. Thank you.
So you can take an Uber.
Please respond the time.
To what?
Hi everyone. Sorry. Hi. We are going to we are going to continue now. Maybe before we continue, let me just recognize a number of people who have joined us here today. I'm very afraid to mention names, otherwise then I forget others. But I remember that when the program was started at UP, Dr. Roberts was part of it as part of the military here at UP. We are also having amongst us CEOs from different hospitals across Gauteng, and we would like to welcome them. Yeah. And we also have Dr. Luvuyo Bayeni, a chief director, if I'm not mistaken, of HRH. I think he's a key stakeholder. And I was saying to him, I'm very excited that he has joined us here today because he's at the national level and he can help us give us policy direction in terms of this profession. So we do welcome him. And we also have the leadership from the province. I think we have more of them here. I'm afraid to say names, then I forget one or a few of them. We also have PHC clinics represented. We also have leadership, nursing leadership from different hospitals. And we are also having professors and Dr. Edith, she's also part of our team. And I'm glad she was here when a mental health presentation was done because she does mental health for us, the mental health presentation for us. And then please now I'm going to welcome, we also have our team, which is our core team responsible for teaching clinical associate. We have Mrs. Lumbani, we also have Mrs. Carvalho, Melissa, Sis Melissa, Miss Melissa Oliphant. We also have Navesh here who teach the clinical associate students. And we also have Sis Imelda who has been helping us organize this. And we also have Tato and Prof, our HOD. Thank you. Now, I'm going to, and some colleagues are still going to come and be part of the panel, so I'm still going to introduce them. Now, I'm going to allow on stage Ms. Aviwe Mkobozi to come in and present. It's just one line before she present. It is important to note that she is the first head of the division in terms of training of clinical associates at VET, who is a clinical associate trained in South Africa. And she has contributed in terms of the profession. She was one of the founders when we started PACASA, a professional association of clinical associates in South Africa. She was part of those who started this PACASA, and I'm glad that she's here today, and she's leading in terms of training of clinical associates. Thank you. Welcome, Afi.
Thank you very much, Dr. Ngobo. It's so nice to say Dr. Ngobo to another clinical associate. My name is Aviwe Mkobozi, and I am the head of the Division of Clinical Associates. I'll be taking you through my master's, which I completed in 2018. I'm currently doing my PhD, which now extends on this master's project. Thank you. Is it moving? It's not moving. I'm pressing it. IT. There we go. I think I'm going to skip the initial aspects because we've been talking about what is the clinical associate, that's come through some of the initial presentations. But just to touch on, of course, this was the basis of the presentation, where I do speak about, at the end of the day, clinical associates were conceptualized to be able to add to the human resources for health. And therefore, the 3 universities offer the training so that community members do have access to healthcare. It is about access to healthcare. It's about increasing the numbers, not only of doctors, nurses, but also other healthcare professionals. In terms of background, I'll be quite brief here as well because I want to get to the results. I thought it was quite important for me to capture that when you look at the history, yes, we all talk about that point in 2001, where in the PIC report, which was formulated by the Department of Health, that they spoke about the need to increase human resources, and that's where the clinical associate conceptualization started. Therefore, training occurred throughout. 2020, HPCSA records 1,000 clinical associates, and in 2022, we have the first PhD by a clinical associate. Yes. Upon going back into history, I thought it was quite interesting to look into the 1940s, where you see that, yes, medical missionaries came down to South Africa and they taught community members skills to be able to see the community members. But there was formal training by the government in the 1940s, and they were called medical aids. And I actually wondered if perhaps there was a relation, or maybe the idea was stopped in the 1940s, and then in 2001, then this concept of a clinical associate restarts. Whether there's a relation or not, I was not so sure. Thank you to the chair of the AIPA, International Association of Physician Associate Educators, so Scott, who has really been looking into the other countries and this mid-level healthcare professional. So you can see there's a globalization of the profession. It's not just in South Africa. But the problem that I was looking into was to say that there are no factors that influence, well, that are known, the development of clinical associate students' professional identity. And that's what I was interested in. Perhaps because of my own journey as a clinical associate and trying to figure out where do we fit in, being in the first class of clinical associates at WITS, and how others would perceive us and how we perceive ourselves. The literature actually has quite a lot on professional identity. And it speaks about how an individual transitions from being the individual from a community. We've all got our personal identities, which are influenced by race, gender, our preferences. And therefore, when we choose a particular training, we are then basically going to undertake that socialization process, and you become a member of this community of practice. So with doctors, very much so, it's become quite a solid community of practice. We've got nurses, we've got other healthcare professionals. But with the newer professions, no one's really looked into how are they socialized. And yes, we teach the knowledge, the skills, and the attitudes, but who pays attention to the human experience? So this is just 2. I won't go into it into depth, but it does speak about how one first functions as a novice, as a beginner on the outside of this community. And as they learn and they train, they collaborate with others, they get socialized, one day they become experts and masters. But it becomes quite evident that through socialization, your identity is formed. So my research question was, what are clinical associate students' perceptions of factors that influence their developing professional identity? And I thought, let me ask the students. This was a qualitative study at WITS. I looked into the students and we did focus group discussions. So I had about 22 first-year students and I had 20 third-year students. The sessions were audio recorded, we did transcription. I used MaxQDA just to analyze the data, and I did content analysis. 3 large themes came through, which I will go into and I'll explain. The first one are the individual factors. So a lot of the students spoke about their own experiences and their aspirations not being met came through. But for some who wanted to be clinical associates, they had a better experience. So the first one, it speaks about the thought of being a clinical associate scares me because I almost feel like if I graduate and kind of become a clinical associate, I would have failed myself. But that's because later on you see that they wanted to be a pediatrician. So there's a disconnect already from the time that they started. The second quote actually showed that once they saw their capabilities and the impact they were having, that shaped their identities because they understood their value. I think the positive factors actually come from myself and seeing what I'm capable of doing. The next theme linked to training-related factors. So the first one, in every theme there's both negative and positive. The first one was quite interesting where they looked at the curriculum and how the curriculum influenced how they felt about their professional identity. So they said because we don't have modules, they're seeing that perhaps maybe the other students are looking down upon them because there's a difference in different curricular structure. The second one speaks about hierarchy. We rank each other. This was even on campus. Even before they start working, they were already ranking each other in terms of hierarchy, and that was contributing to the identity. But when you see the difference you make in someone's life and knowing that, no, that was my knowledge, I put that in my head. I actually went, studied that skill. Then there's a sense of pride that comes through when they acknowledge their capabilities. The third theme was looking at now the identity of the profession as a whole. So the first one, it speaks to how the other healthcare professionals did not really regard their identity or their profession's identity. So it says, doctors refuse to address you as a clinical associate. That has a direct impact on how they see themselves as a clinical associate. The next quote, it says we interact with them as doctors do, and because I'm seeing the time. It centers our identity around a doctor, and because our identity is centered around what doctors are, we have no clear identity. Identity is a social construct, and in as much as individuals, we want to affiliate to certain groups. The society around us, it has an influence on professional identities. And the last one, they feel undermined, but we do so much more. I thought it was interesting that one of the quotes from 2018, the student is speaking about, I need someone who can be a father figure, something to me, because I'm a clinical associate. I'm not a doctor. I need to know how to practice within my own field. I want to learn how to do that. Instead of, oh, doctors do this, do that. Oh, nurses do this. They were looking for their own path. But if you look into the 1940s, the same narrative is there. And a gentleman called Edward Jali is saying, whenever I go, people believe that I'm a doctor. And he was a medical aide. But in thinking that they flatter me, others call me Inyanga. But isn't Inyanga a witch doctor of higher status than me? He is licensed, I'm not. So he goes on to speak about, and this is in an article by Vanessa Noble, how he appreciates his role, but there's a lack of appreciation from the people around him. And that's so many years later. So I think I managed to publish this in an international journal, and the recommendations that came from it were that firstly, educational strategies need to improve. So in as much as we teach the skills, the attitudes, the knowledge as educators, we need to support the students to develop their professional identity. There needs to be strengthening of interprofessional teams so that the nurse is able to know their role, but the clinical associate knows their role, and everybody knows how to work together. Marketing and advocacy is important with the institutions, organizations, but also Department of Health, so that everybody is aware of these newer professions. Stakeholder involvement is important because students do talk about career pathing. They do talk about job security, financial security, and therefore that would mean HPCSA should look into the practice guidelines for clinical associates. We're also now getting a lot of specialists wanting to hire clinical associates, and the guidelines are almost taking time to respond to some of these needs. And yeah, I mentioned Department of Health, I did. Okay. So therefore, just to add, It is not our differences that divide us. It is our inability to recognize, accept, and celebrate those diverse differences. And there really is power in diversity. Questions? Okay.
I love to hear her speak, you know. She's just so poised, you know. And so thank you, Aviwe. I, I just want to say something about your medical aids in the 1940s. Just a quick sort of anecdote is that in my first experience, I think, with this particular health professional, and actually speaking to those that are Southern African, was in the mid 70s. In 1976, you remember there was after the riots, the 1976 riots, those of you that remember, not all of you remember, but there was an exodus of people that left South Africa, young, you know, leaving South Africa, and they descended on a lot of the African countries. These African countries didn't have the capacity to take care of these people from a healthcare provision. And so the then African Union actually decided, you know what, they need to take care of their own. So in Tanzania, they actually came up with a school where they recruited people who wanted to do something within the health field, and they trained them. And so that was my actual first experience with the clinical associate profession for South Africans. However, I do want to say that we went to another session somewhere else, and it actually even predates the mid-70s. You know, it's just that it was not known. And so when Aviwe talks about, you know, professional identity and who are we, you know, and how we struggle with it, it's not something new. I think even in the United States, sometimes it happens. I think one of the things that us as educators need to do is actually have as part of our curriculum a way for them to get to sort of hone in this professional identity. But I think most important is when we send them to the clinical area, we need to send them to places where clinical associates work as well, which means, MEC, all your facilities need to hire clinical associates. Moving forward, I would like to introduce our next presenter, who unfortunately is not here with us, but there is a video of his work. I actually was an external examiner for him, for his master's. But before that, he was in the first group. Yeah, he was one of my first students, as was Dr. Ngombo. So it's always, for me, this is exciting because I get to see how my students are progressing and what work they're producing. So he's actually going to give us an insight into the attitudes of stakeholders. You see, I don't even have to read, you know, the thing, because I remember reading his article. And I actually got quite a few insights. So I'm really excited that he's able to to present his work and his research here.
Good day, everyone. My name is Arthur Bakan Setlapel. Thank you to the program coordinator and the team for the invitation. It is an honor for me to share this scientific research with everyone. I will be brief and do a focused presentation because we have 10 minutes. My presentation will be about the research titled Stakeholders' Views on the Utility and Employment Strategies of Clinical Associates in South Africa. Hear about the introduction, methodology, results, recommendations, strengths and limitations, and the conclusion. First graduates of clinical associates joined the health system in 2011 with the aim of increasing skilled health workforce. The intention of the National Department of Health was to include clinical associates in the OSD, the occupation-specific dispensation, also to create posts and clarify their position in the healthcare team. Unfortunately, more than 10 years later, the policies have not been signed into agreement. Therefore, the perceived strategic dilemma on the utility and future of clinical associates in South Africa needed to be explored. This study explored stakeholders' views on the utility and employment strategies of clinical associates in the public sector. The research was conducted in South Africa between 2020 and 2021. Ethical clearances were granted from relevant ethics committees. On research methods and design, we used a mixed method study. Online survey was used to collect data from operational stakeholders. Online interviews explored strategic stakeholders' views. The study was conducted at 5 provinces in South Africa. We started with quantitative phase, then prepared for the next phase, and then we conducted qualitative phase, then interpreted the results. The stakeholders at operational level were hospital CEOs, clinical managers, nursing services managers, and HR managers. Invited stakeholders at strategic level were from the National Department of Health, Provincial Department of Health, academic institutions, regulatory body, bargaining council, professional association, and trade union. Academic institutions assisted us in identifying hospitals with employed clinical associates. The questionnaire that was sent out had 7-point Likert scale. 1 was strongly disagree, 4 neutral, 7 strongly agree. We also had multiple choice questions and open-ended questions. A semi-structured interview was based on the quantitative survey data. We used data 15 for the survey and measured means and standard deviations. Audio recordings were manually transcribed, analyzed, and themes were reported. A total of 76 survey questionnaires were sent out to participants at 21 hospitals in 5 provinces, with the response rate of 59%. In terms of the results, participants strongly agreed that conditions of clinical associates practice were met, and that clinical associates are able to work with other healthcare workers and contribute to healthcare service delivery and improvement. Over 90% of participants reported that clinical associates contributed to the overall management of burden of diseases, namely HIV, non-communicable diseases, tuberculosis, injury, and trauma conditions. However, clinical associates were not routinely found in specialized areas like obstetrics and gynecology. With regards to the recruitment and retention strategies on clinical associates, the participants reported low agreement. The table is showing positive contributions of clinical associates in dealing with quadruple burden of disease, ranging from 91% to 96%, except for maternal and women's health, which is around 17%. Perhaps that area needs some attention in terms of research and improvement. On employment strategies, participants disagreed that clinical associates at their facilities have been provided with opportunities for career development and promotions to higher notches and posts. On this table, it is important to note that participants disagreed on the positive impact of recruitment and retention strategies of clinical associates. For example, they disagree that there's been gradual increase of clinical associates employment at their facility. On the key findings of the quantitative phase, the radar graph shows the high positive utility impact of clinical associates on service delivery within hospitals, followed by their ability to work with others and having individual professional awareness. The radar graph also shows that participants view clinical associates as meeting their conditions of professional practice. There is, however, low positive agreement for both the impact of recruitment and retention strategies on the utility of clinical associates. In the qualitative phase, we invited 12 strategic stakeholders. 6 participated in the study. They were from Department of Health, academic institutions, and professions regulatory body. Themes from the interviews were around scope of practice, career development, post for clinical associates, and CPD activities. On the scope of practice and professional autonomy, interviewees agreed that over time, the current scope of practice provides for increased professional autonomy. The increasing level of trust between clinical associates and medical doctors have shown to lead to less need for direct supervision. The approach of supervised practice was reported to be protective from medical legal challenges. Furthermore, interviewees argued for some form of clinical associates independence practice following clinical flagships. They also reported ongoing proposals submitted regarding this shift in professional autonomy of more experienced clinical associates. In terms of career progression, slow progress was, however, reported. More postgraduate courses that matched the burden of disease were needed, but that progress in registering additional qualifications for clinical associates with the HPCSA is slow. On the matter of posts, the interviewees accepted the outcomes of the survey on post for clinical associates. Here is a quote from the interview. On continuous professional development activities, interviewees reported that there were not enough specific CPD activities for clinical associates due to unavailable entity that would be responsible for them. On recommendations and implications, it is recommended that additional strategies and policies that support the recruitment and retention of clinical associates in the health system be implemented. The implications of the study are, firstly, creation of more posts, career progression, consider internship concept program to support autonomy. Look into more areas of specialization for clinical associates and specialized employment in those fields. And limitations of the study. The mixed method approach were the strengths of the study because qualitative findings were further explained in the qualitative phase. And in terms of the limitations, the study was conducted during COVID-19 pandemic. Therefore, that might have affected the response rate of the study. In conclusion, the utility of clinical associates is clear. Their contribution is valued by hospital CEOs, clinical managers, nursing services managers, and HR managers. But clinical associates appear to be overlooked higher up. The findings support the need for the growth of clinical associates. Strategic stakeholders were aware of the challenges faced by clinical associates. We hope and believe that the findings of this research are able to address the strategic dilemma around clinical associates. The lack of progress around many of the human resource issues, including the 10-year delay in including clinical associates in the OSD, is a constraint that needs a champion if the clinical associates program was to reach its potential. I thank you all.
Thank you very much, Bakang. He's not here with us, but he has joined us online, so he will be available to answer questions. Before we go to our next speaker, can I request all the panelist members to please go up? We need just to prepare your mics so that when you speak here, we can hear you quite very well. So I'm going to request Dr. Luvuyo Bayeni, Prof. Richard Cook, and then Prof. Yani Hugo, and Nompumelelo, are you here? Okay, thank you. Yeah, sure. We can go to the station there. Unfortunately, Prof. Mbogazi can't join. He had other urgent issues to work on. And then, Kala, are you here? Thank you. Yeah, you can just go to the side. Thank you. Now I'm going to, so in Zulu we say, into emnandi iyapindwa, meaning that if we've had a good presentation, we need to hear more. So I'm inviting Scott back. Scott, can you please come back and share more with us? 8 minutes,
Yeah. Great. Good afternoon. Nice to see you all. And we've had a nice lunchtime, so we're feeling a bit good with our bellies. We're pleased the MC is still with us. Thank you for sharing. I know this is very fruitful and productive for everyone. So I'm going to be 8 minutes on the clock. And this is now takes us back to 2012. This was a study that was done with colleagues from the Wits University. And we looked at a qualitative cross-sectional observation study. And we looked at the opinions of the supervising physicians of clinical associates at the time. Now, I must bring you back to 2012, and the students from WITS, raise your hand. And there are 81 year 3 students. And at the time of 2012, we had 93 clinical associates in practice. So you represent the group of clinical associates that were in practice in 2012. And how many do we have in practice today? How many have graduated? 1,581. So 2012, we had 93. We now have 1.5. So at the time, 37 of these clinical associates were training in the Northwest. So at the time, we had bursary programs. Northwest Bursary provided a 3-year bursary for education and then a 3-year employment post back in the province. Gauteng had done the same, KZN had done the same, Mpumalanga had done the same. Unfortunately, those have slowed down, but we're here with the MEC to encourage her to look into bursaries again, within the province and other provinces as well. I think we know the benefit of education and of employment after education. Now, what I'm really pleased with is authors' findings resonate for us 10 years ago. So authors' stakeholder engagement and success of the CLINAs was actually, back here in 2012. So I'll just share with you, there are 28 physicians who were teaching, supervising, and coordinating the clinical associates in the hospitals of the Northwest and of Gauteng. So I was able to recruit 24 of those supervisors. They agreed to do these one-on-one interviews. We didn't have Zoom back then, so it was in person or it was on the telephone. I'll get to that just now. And we were able to cover 37 of the clinical associates that were practicing. They worked in emergency, internal medicine, obstetrics, gynecology, outpatient, orthopedics, and surgery. So we did 20 to 30-minute interviews. As I said, in person or by telephone. They had informed consent, of course, before the interview, and we received our ethics approval from WITS at the time. So it was very much open-ended questions. We had some pointer questions to start, but we really wanted them to share with us what was going to display their feelings and their opinions about the clinical associates who had just started working. Really, this is their first year of employment. We did inductive content analysis, so from all of the interview results, we worked through themes and sub-themes, and we were able to make categorizations of them, and then we coded these so that we could present them for you today. So here's the results, is we had 3 very strong themes in professionalism and in skill level and in effectiveness of patient management, and then some themes that needed some work were in overtime calls, writing prescriptions, and supervision. So quotes are really important when you're doing qualitative studies, and in this case when we're doing interviews, and the quotes speak for what we're finding out, and they have the theme. So in professionalism, they're very supportive roles to senior doctors and specialists. If you teach her, she improves on it. We have good communication, and they have good communication with other professionals, and considered part of the team. These are ideal professionalism attitudes that were displayed back then, in 2012, from our students. Even though, as Aviwe has pointed out, clinical associates were still looking for their identity. Who were they? But they knew the base level a professional means to be in a clinical space. Really important was they knew their limits. As a professional, we trained for common conditions in South Africa for a clinical associate, and they knew where their limit was. They knew where they needed to reach help. Once they learned about that patient, they could then see that patient again without help in the future, because they had good clinical skills and good judgment. They also had a very wide range of skills. The doctors were impressed by how much they could perform. They're also great with assessment and patient management, and waiting times were reduced because of the addition of these new providers in these hospitals. So patients were really benefiting, which was the point that Aviwe was making, is we were really to help with patient access and increase for patient care. Now, there were some things that were pointed out, which of course there always needs to be. Lack of clear space and structure, lack of overtime duty that would enable them to be really helpful in the hospital. Also, they should be allowed to function independently for scripts. So at this time, 2012, we did not have a scope of practice. The scope of practice was only passed by the Minister of Health in 2016. We were working with a job description created by the National Department of Health for the first graduates working in 2010. So it was quite unclear what clinics could do at the time. But you could see the doctors on the ground wanted them to be able to provide prescriptions, which our education and curriculum does. I know you students, you guys know how to prescribe. You know what medicines are possible up to Schedule 4 or higher in emergency, as now dictated by our scope of practice. But unfortunately, still today, clinical associates who are practicing can't prescribe on their own because the health law doesn't reflect clinical associates as prescribers. So that's one of the things we still need to work on, is to get the health law and the Health Act to reflect clinical associates as prescribers. So back then they wanted them prescribing, and today we still need us prescribing. Okay, we weren't sure of the scope of practice. They weren't sure what they could do because we didn't have a scope of practice. It shows how important it is that we do have regulation and we have law that guides us. And also they weren't sure about supervision. Can you place them anywhere? How do they need to be supervised? Our scope of practice now says a graduate from 1 to 2 years of practice has direct supervision. And a graduate with 2 to 4 years of practice has indirect supervision. And a graduate of 5 years can practice independently, but always in contact with a supervising physician, which is how many of our healthcare practice, in teams, and we always are collaborating and reaching across for consultations. You know, it's no different for us. Also, they thought there was not enough exposure to emergency medicine. This was in 2012. They also thought they needed more surgery during their rotations. So this information that we gathered helped us to inform our curriculum. At WITS, we started a 2-year surgery and a 2-year anesthesia rotation, which stretched now. We now have a 4-year surgery rotation and a 4-year anesthesia rotation, because we realized that the students needed more information, more education here. We also really found that this was important for developing of our honors. So we then developed a BCMP Honors in Emergency Medicine course based on a lot of this information that came out from this study. So we can see it's really interesting that what Author has today reflects back from 10 years ago. We have real strong professionalism, we have very strong skills, we have good patient management. Clinics know their limits, they're safe practitioners. We also know there's areas still to work on. And some of these resonate from 2012, but there are also newer areas that we need to work on. I really want to thank my co-authors that did this, and I also want to encourage students about doing research. This was one of my first papers that I worked on, and the data was 2012, and there was a delay in getting us going and starting it. I picked it up in 2018, and I submitted our paper to 2019 to a journal, 7 years later. But they found the information really important as a baseline for what's happening in South Africa, a place we could look to when we started. And then it took a full year of back and forth with the editors to help me to get the wording right, get the structure right. They were very helpful in helping me edit it. And by 2020, I then had the publication come out with my co-authors. So I encourage you to stick with your research. I encourage you to get involved. All information that you collect can really influence curriculum and can influence our scope of practice and influence our professionalism here on the ground. I thank you very much for the time again.
Thank you very much to Scott. And I'm actually even wondering whether what I was going to present really will add value. And I'm thinking that we actually need to go to the panel, but I do just want to sort of maybe just make some comments about some of the things that you talked about with your research. I think from a historical standpoint, as you recall, Scott, we also worked on some recommendations that we were tasked to give to the National Department of Health, which was supposed to speak to some of the issues that you brought up when it came to the challenges. And unfortunately, we're still kind of in the same place. And I really think that it's time to sort of step it up a little bit. I think one of the things that I'm not really sure what Professor Steenkamp has in mind with respect to the specialists, but to the panel, but I think one of the things maybe for us to comment on is the fact that even this clinical associate profession has actually evolved. I remember when we started, and I think Aviwa had as part of a timeline, the task team and what the PIC report had recommended, in response to that, in that original, our original curriculum and what we presented was that clinical associates would be very useful in the district hospitals. And the idea then was that we actually needed more consultants that would be out in the communities. But it seems that that need has shifted. And we found that really the clinical associates work better in the community. And they can identify people who then need to be up-referred. So we've switched that. And I think you talked about how pliable clinical associates, the profession, is globally. And that is exactly what we did with our curriculum. We tweaked it. So we still value what we think clinical associates can do within the district hospitals, but there is now more of an emphasis on outreach, because even if you look globally, that is what is happening. What we're saying is let's take health to the people, as opposed to sitting in an institution and waiting for those people to come to us. So that has changed. I'm glad that you brought up this issue around prescriptions, because it really has been a problem for us. I think one of the things that you probably didn't mention, and I would like to mention, is that the previous Medical and Dental Board, not the current sitting one, but the one where Daniela and I were part of, they actually agreed for us to have a working group in response to this concern about continued supervision for clinical associates 10, 15, 20 years into their careers. And so we got people from the private sector, we got doctors from the public sector who supervise clinical associates, we got clinical associates to also come and speak about their experiences, with the view that probably we needed to really look at the scope of practice and actually look at, sort of what the supervision means. And we did take it to the board. Unfortunately, this current board has not taken it forward. But recommendations were actually made to change even the scope of practice supervision rules to allow clinical associates who had experience. And I think the caveat should be, it's not that you can work 1 year and then you leave and then you come back after a year and then you leave, but you have to have continuous practice, continuous exposure to the healthcare system. And that the recommendation was actually that after 5 years, clinical associates should not be supervised. Obviously, that means a change even in our curriculum, but we can't implement that if that has not been made a resolution, and therefore, remember, we have to go through the process of changing the scope of practice. So that is the other thing. I think this issue of prescribing really becomes frustrating. I want to say that it's a lot more frustrating for maybe younger people who are trying to find their place. I mean, I worked at TDH at the outpatient department, and it was not an issue for me. But maybe it's just because at that particular time I was pretty comfortable in who I was. So it does become difficult. But it was the only issue that I had with prescribing was that I felt that my patients had to wait for somebody to co-sign my prescriptions. But there was never an issue where I felt that whoever was supervising me was second-guessing my whatever management plan I had implemented. And that always brings me to this idea of the fact that us as educators, really, that's where we need to work. We don't have a problem with teaching content. I truly don't believe we have a problem with that. I think we have a problem when it comes to facilitating this, giving self-confidence to our youth. You know, they come from all walks of life. And I think we put our heads down and we think we've got to teach them all this content, but we're forgetting that socialization. And I'm actually challenging both WITS faculty and UP faculty that really that's what we need to start looking at. I want to finish just very quickly because nobody put a time for me. Now, my talk was optimizing the clinical associate in South Africa. So what I would like to do rather is actually share what I used to do when I worked. I worked for a group of doctors. And one of the things that we talked about is, I think if you look really quickly, I'm going to just divert very quickly. Statistically, it looked like a lot of clinical associates were going into the public sector. Now, the truth of the matter is the public sector doesn't hire them. It's very difficult for them to find jobs. So a lot of them are going into the private sector. That's the reality, right? That's the reality of our situation. Having said that, if you're going to be marketable, young people, in the private sector, you need to know your worth, right? So I worked for a group of doctors who both had rooms, doctors' rooms, and also in the hospital. My responsibility, first thing in the morning, was to go around on all the patients that they had. Now, there were 7 doctors, so you can imagine the load. That was my primary responsibility. Every day I had to pre-round, so that by the time they came through, because they would always start at the intensive care unit, and I would start in the general wards. By the time they came through to the general wards, I would have already called them to say, in this ward, in this bed, this is what you need to think about for this particular patient. But this is what I've already initiated management on. Do you agree or not? That was the first thing. By 10 o'clock, I had my first patient in the doctor's rooms. And my role there, because I worked for specialists, my role was to see every single new patient that was referred to us. I had to work them up, every patient. And my schedule was full. And every other weekend, I was on call with, out of 7, 1 other doctor. So I was in the hospital the whole day rounding on everybody's patients. Any calls that came through, I was the first call that came through. Any patient that came to the emergency department, I had to go to the emergency department and decide, do we admit, can we treat, and see them in follow-up. That was my role. That was what I started doing 2 days after I graduated. That is what I started doing. And that is what, and I want to say this to the young people. I did this very intentionally because my goal was always to come back to South Africa because I saw the potential of this. And I still see the potential of this. Every time I interact with students, I see their potential. And it bothers me when there are people out there that don't see that potential or say things that they don't realize are cutting the self-confidence of these young people. One of my first-year students said to me, it really just absolutely shattered me. She was talking to an intern, and the intern said, well, you can do the technical stuff and I'll be the brains. No. Meanwhile, I'm telling my students that you are not at the University of Pretoria, you're not at Wits University by mistake. You had to meet the admission criteria. It's not a mistake. If you don't meet the criteria and we don't think that you can go through the rigorous academic program for you, we don't take you, we don't accept you. Some of my students can attest to that. We don't say, oh, shame. No, pull up your socks, right? So what I'm trying to say, so when I say the optimization, that's what you can do. But in South Africa, obviously the context is a little bit different. But it doesn't take away from the capabilities of what we can do. What we need to do, MEC and colleagues who work in implementing policy, is make sure that we understand what it is that the clinical associate can do, what our policies can do. We need to go back and we need to engage HPCSA and the Medical and Dental Board and pick up from where we left off. And let's get the show on the road. That's all I'm saying. Right? Now, in the United States, the history was, when the profession began, they saturated the primary healthcare market. You know, that's what they were known for, primary healthcare. It wasn't until the primary healthcare market was saturated that specialists started looking at clinical associates as viable to work in their practices. When I went to work 2 days after I graduated, I was the first mid-level healthcare provider in that town. And a year later, that doctors were like, wow, where do we get these? Where do we get these new toys? Okay, so for those of you that are not sure and you think, I don't know if I want to do this, yes, you do. Our people need quality healthcare. You collaborate with other people and give them that quality healthcare that they deserve, that they have earned. Your parents have sent you here. Now I'm speaking to my young students because you guys are sitting here. Your parents have sent you here. Make them proud. You know, those of us that are policymakers, that do research, that teach you, we will do our part, but you do yours. Now, that's all I have to say. Thank you very much. I now am going to leave it up to Professor Steenkamp. But what I would like to quickly do is just introduce our panel. So Professor Steenkamp is going to chair the panel. I think what we want to get out of the panel is ways forward. You know, based upon the research that we've shown and my getting up and speaking, what is it that we want to get out? What are some things that we know that we can do? And we have got, as part of our panel, Dr. Lovuyo Bayeni from the Department of Health, HRH. We've got Professor Richard Cook, who I'm excited is part of the panel. I have to be honest though, sometimes when Professor Cook speaks, I'm like, I don't know what you're saying. Then I have to think about it because, you know, not, so if you guys don't understand what he's saying, just raise your hands, okay? And then we have, I'm happy to see, also on our panel is the grandfather of the Clinical Associate Program, Professor Hugo. Nompumelelo Mahlambi, who, thank you very much, is representing the Professional Association, is also here. I'm actually excited to say that I'm happy to see that there seems to be sort of this renewed energy in the Professional Association. And I really hope that they can take us onto the next step. And I have engaged with Nompumelelo before. I believe that she's got a lot of work to do, but I do believe that we're in capable hands with her. Is it from here? And lastly, we have a student. And I'm excited that the student who appeared to be nominated is a first-year student from the University of Pretoria. And I did. Yes, why did
I didn't say anything.
did I not introduce Prof. Cook to you guys? I did.
Fine here next to me.
Okay.
Yeah, you're fine.
Have I left anybody out, Sandele? Okay. All right. Then, Professor Steenkamp, I'm going to leave it in your capable hands. Thank you very much.
I see now why the time isn't being done because the minutes are here in front of you indicating how many time you've got. Oh, no wonder you. Oh, okay. That's one way of doing it. Eh? Well, good afternoon to the MEC, the CEOs that are attending this afternoon, and then ladies and gentlemen in present and then also online. Welcome to this panel discussion that we have, and naturally to my panelists, my distinguished panelists that are joining us today, and they've all been introduced to you. What a wonderful lectures we've heard today. So informative, so true, and there's really, I think, I can really say the gaps have been identified and what we should be doing, but we still need a lot of discussion. It has been reiterated today that clinical associates play a pivotal role in the healthcare ecosystem. These highly trained professionals work in collaboration with physicians, nurses, and other healthcare providers to deliver comprehensive and patient-centered care. They are the unsung heroes working tirelessly to bridge the gap between healthcare demand and supply, ensuring that patients receive timelessly and high-quality care. So during this panel discussion, we will embark on the journey to map the future of clinical associates in South Africa in their healthcare. The role of clinical associates is evolving, and their potential to shape the landscape of healthcare has never been more evident. I'm going to start off and ask Professor Hicho to provide us with very short, please, panelists, because we unfortunately have gone over some time and we really need to get to the crux of the matter. Historical perspective on the inception of the Clinical Associates Program, as well as the crucial role that clinical associates play within the National Health Insurance Framework, connecting the program to the broader healthcare policies.
Thank you. Can you hear me?
Yes, you're not mic'd up.
No, they said I would be fine.
You're all fine.
All right, they said so. Okay, so I mean, we can do this session on a fireside for a whole weekend as to where it started, but you asked me to be short. Let me first say the clinical associate medical aid worker called Joali in the 1940s. He worked with the Karks. He was a full partner of Sydney and Emily Kark. So the start of community-oriented primary care is a clinical associate start, because he was part of that success. And I think we're back to there, because Sydney and Emily wouldn't have been able to do what they did if the Zwalis, and it's actually a husband and wife pair, if they weren't there to actually work with the people. The second point of the history, okay, this is not so important, but when Minister Mantu Chabalala Mshimang in 2001 said to the HPCSA, you will start a mid-level program, everybody was saying no and was angry. But I'm silly enough, I said, guys, if we don't do it, somebody else will do it. So we picked it up. In the first year of working on this, there were only 2 people whom I spoke to who didn't want to kill me. And the one was the late Sam Fersen, the family physician, and the other one is now the acting head of family medicine in Limpopo, University of Limpopo, Gert Marinkovic, another wise man. So I'm just saying that's where we started, doctors, nurses, whatever. But then we went on a study tour, and actually the Deputy Minister, Sibongiseni Dlomo, was with us, including Kami Chetty and 2 other people. We went to the States and we went to Tanzania and places, and we started to work on the task team. That's part of that. The other thing in terms of the history that's significant is when we had to decide on a name, it was a whole issue. What shall we call? We were looking at assistants. We said we don't want assistant, even if it was physician assistant. We looked at officers. We say this is not the army. So we came up and chose associate as the name to indicate the collaborative aspect of the profession. So in the core of the name was already the vision of collaboration, interprofessional work, etc. And Madam Chair, the rest is history. In terms of the NHI, the role that the clinical associate can play, the versatility from the home, the community health worker, the clinic, the hospital, no other profession that I've met is as versatile as that. We should just pick it up and make it work. Thanks, Madam.
I'm telling you, I don't think anybody could have put that better, stated that better. It is really so true, I think, and we will pick this up during this discussion. So many things have happened and brought us back to remember how important, and I wish we had millions more, really thousands more, clinical associates, especially during things like the COVID pandemic. And from then on, we know even more. And I'm so glad this can now rise up from that, and that we can have more people, especially where we're going in healthcare, and that we can see the importance. With outbreaks and everything, we need the clinical associates. I'm then going to move over to Professor Cook and ask him to share some of the insights into the Wits University experience in training the clinical associates and shedding light on the program's past achievements and future plans, especially in terms of maybe also postgraduate qualifications. Thank you.
Thank you, Vanessa. I have the privilege of being the head of Department of Family Medicine and Primary Care at Wits, and in a very privileged support position to Ms. Mgobozi as the head of Division of Clinical Associates, and her quite simply amazing team of clinical preceptors, lecturers, and administrators. The journey that we've had at Wits has been what I might describe as a very real one. Now, that might be a neutral comment to make, but what I mean by that is that it's been a journey of considerable ups and downs, not least for the growth of the numbers of clinical associates has been an excellent positive to our program. As Scott has alluded to in terms of the numbers, Wits has been contributing to a significant number of those. That's been a real positive, and the start of our BCMP program, the BCMP Honours Program in Emergency Medicine has been another real plus. And in fact, even the very initial establishment of the division, to be frank, for it falling under rural health and the Centre for Rural Health initially, but coming into its own as an academic division was also a real highlight. Of course, the more recent appointment of Ms. Mgobozi as a division head who is a clinical associate and very much representative of excellence within the profession for being a clinical associate herself has been a real highlight. There has been the struggles equivalently with just ensuring the place and space within the School of Clinical Medicine of the division and of the work and the vision of what can be contributed to within the service context by the School of Clinical Medicine overall, not for the support of faculty per se and the leadership of the school and the faculty, no, but what I'm speaking about is just trying to entrench the value add and the understanding thereof within the training platform as a whole. And I have been responsible for the extended academic platform at Wits in terms of the development of that, using different catalysts. I've been responsible for the Nelson Mandela Fidel Castro program, which has also been in our department, and for the clinical associates. Both have been catalysts for the strengthening of the extended platform. And we're just on the cusp of some real successes in that regard, in terms of the sustainability of an extended platform of training and service in an integrated manner. We're not there yet, but I have high hopes for the future of that particular endeavor around an integrated training and service space. I've got much more to say, but perhaps I should pause.
Yes, I think, I think this shows also the excitement, and thank you so much about it. I think everybody is so full of energy to go forward, to move forward. And, we just hasn't got the time to actually discuss this. And I think maybe another Indaba is really needed so that we can have that platform, definitely. I'm going to move over to Dr. Bayeni now and ask him if he could provide us with a national perspective representing the views and initiatives of the National Department regarding clinical associates.
Yeah, thanks, and good afternoon, colleagues. It's so unfortunate that a week ago I used to say I'm a newly appointed, so which took away a lot of pressure from me. But now, after 3 months of being in the post, I can't say I'm newly appointed anymore. So I must bite the bullet as it comes. Thanks. I am now responsible as a Chief Director for Human Resources for Health in the National Department of Health, which basically means we're supposed to be responsible for planning, training, as well as management of the health workforce for the country. And by virtue, this topic that we are discussing today on the future and our prospects for clinical associates therefore falls under our domain. And I must say that I was also enticed with a 30-minute conversation 2-3 weeks ago at the Rural Health Conference, where I met a clinical associate there that was presenting an experience and contributions of clinical associates in the rural health space and service delivery. And this is the second platform that I'm getting to be more enlightened in terms of the clinical associates. However, I do have my own personal encounters, having received the first group of the WUSU graduates when I was a clinical manager at a district hospital in Somerset East. Wow. And I know quite very well the impact, the role, the relationship, and the effort that the clinical associates have put into making sure that the services that we render are better improved. So I do have my own fair experience in terms of how we have utilized, how we continue to make use of the clinical associate, and how we have benefited, especially when it comes to the district health services and the rural health space. So I'm not new in terms of the space, but of course now the CAP comes with more responsibilities. I do take note that as a department, we have had a phase where we might have unawarely or unintentionally stepped on each other's toes. We are sitting already with a ongoing report that we must submit to Public Protector as having some raised, I don't want to say reported, but as being raised by the PACASA on issues that are of concern. So we are quite aware of the issues that we want to raise. And the future that we are trying to work on is to, especially as a new approach, is to say we would not do or decide or have any intentions or plans without engaging the stakeholders that are involved. That includes PACASA, that includes the academic space. Fortunately, we're not looking at so many institutions like the other faculties that we need to deal with. We are only looking at 3 institutions that in the core are producing the product for us. So our intention is going forward is to ensure that we do roundtables, we do consult. There's a lot of policy review that needs to come into place. We are mindful of the issues and concerns that are there in terms of how we are not availing or when we do avail little posts in terms of the appointments, but even in the posting themselves, the issues of the hierarchy, the issues of the growth, we are very much mindful of those. But importantly for me, which I engaged the clinical associate I met more, was the issue of where to from here. Because equally so, we need to be on the same wavelength in terms of understanding what our career pathing is going to be, what our future prospects are going to be, and what do we intend to have in the next 10 years. It's not enough that we can massage and be comfortable with producing when we do not have a vision or cannot confirm where we want to go in the next 10 years or so. So that's our approach in terms of the National Department of Health now. I'm tasked with that responsibility. And my personal approach in terms of entertaining and discussing issues, it's all about consultation. We should be able to sit around the table and we should be able to even communicate with each other. Sometimes you might say things you don't want to hear, but the best way of dealing with them is when we can sit around the table and say those things at the end of the day. Thanks, sir.
Thank you very much. So true. This is the whole thing. You know, I mean, we can't just leave it. We've got to face it, discuss it, and get over the problems and go to the future, into the future, because otherwise we aren't going to get there. And it's also just going to be discussions upon discussions once and again, or over and over. I'm now going to turn to Ms. Mashlambi and ask her if she will just address some of the aspects, or I must actually say the challenges that clinical associates face in their role.
All right. Thank you very much for that. I think...
Yeah, we'll keep it brief. Okay.
I've mentioned the Public Protector already.
Are you speaking about challenges in the workplace or challenges in general?
I think we can say, in their role, so it can be in general, it can be in the workplace as well, because it basically takes others both together, so you can just refer to the ones maybe that you think are the most important. Otherwise, we're going to have quite a list of them. So I think let's see which are the ones that we should tackle first, which are the most important.
All right, thank you for that question. And I think they've already answered it, and it's all about personal identity. As individuals, you need to know yourself. You need to know what talents you have and what you can contribute to other people. If when you are not confident about yourself, you can't expect other people to be confident in you. So it's all about knowing yourself. It's all about refining yourself. It's all about letting people know what you do out there. And I think since we're on this topic, it's all about, we need, this platform is us creating content about clinical associates. So we need to take it out there to the stakeholders. We need to take it out to the Department of Health. Some people don't know what we do. So it's all about using these platforms and taking it out there. We need to talk to all the stakeholders. So yeah, I think that's it. Thank you very much.
I want to say thank you so much for that. That is the first thing we started off with when we started having a look at where do we go forward, is what is your identity? You must have a name, you must have an identity, something that brings us all together as a profession. And explaining, for students to explain what is, for instance, a clinical associate, or what is actually quite bad, actually, is all these 33 other names. How are we all ever going to bring it together to have one name that everybody knows? Like a clinician is a clinician. You know, I mean, we specialize further. But when we get to a clinical associate, 33 names, I mean, it differs across the world, and there can be a misunderstanding of who and what we are. So that is very important. And as I said, that was our starting point, to say so that I can feel a belonging. I must feel I belong somewhere. Okay. The next person I'm going to ask is Miss Waterson. And I want to ask her, what is your experience in the program? As I know you're only first year, but you know what? You know, even just being in there for that, how are you feeling about the profession, young? And I've done this on purpose. I hope you see that I started at the grandfather, and I'm looking at the future. And that's why I'll be going out. So the future of us. But I think if she could tell us now already what's the problems, let's see.
Just like my experience in the course so far, I'll keep it brief. Overall, as a student in the clinical associate program, we've worked quite a lot in hospitals, and that is something that I personally appreciate. It gives you an idea of what exactly you're getting into. It gives you an idea of what you're working for. The program itself, one thing I would like in the program is a bit more guidance, honestly.
Okay. Whoa.
So, as it comes down, as we talked about earlier, personal identity. We need confidence. And it's very hard to be confident when you don't feel like you know what you're doing. Oh, even the bits. Let's go, guys. So, and I understand where they're coming, or where everyone's coming from, of we need to pull up our socks, we need to do our own research, and I agree with that completely. You don't want a clinical associate to, oh, I don't know how to do this, I'm just going to ask someone else and not learn. But I do feel there needs to be a bit more of a balance. But on the other side of it, I can also see that there are some things that the program is implementing to help us. So, for example, mental health days. They are. Point is, they're trying. Let's take it. But overall, my experience in the program is very fulfilling. I feel like I've made a difference in some people's lives, whether it be students, like fellow students or patients alike, and I'm excited for the future.
Excellent. I'm telling you, that is really warming words. From somebody that is in first year and studying and says, I already feel I've made a difference in someone's life. I think that is really, wow, to me that is really, that is exactly why we're here. In any profession, if you can say, I've made a difference, and you really feel you've made a difference, but you should feel this, really because you interact so quick. And I think that's the beauty of being a clinical associate, is the very fast interaction that you have with patients already. I also think one thing that you're speaking to and did I even introduce myself really? Did I? Did I tell you that I was, okay, sorry. Now that I'm thinking of it, I am Vanessa Steenkamp. I'm the Deputy Dean of Teaching and Learning, by the way. And the one thing to me that was so important about what you were also saying is pulling up your socks, reading more, learning more. And I think Marzuki said the whole thing about 2 days after being or finishing. That is one of the skill sets that we want. And we are going to be changing the curriculum for people, and we expect you to be lifelong learners. You will never be full learned. I'm a student. I'm still a student. I mean, you can even ask Prof. Vichu, even though he's now the grandfather, okay, of the fraternity. And I don't mean grandfather now with maybe, what do you call it, smaller, with children, in that sense. But you know what? Students are all our children anyway. To just tell you, but the skill set that we require of people going into the future is one of forever learning. And the sooner you can start learning that, the better you can do that. And she said after she's qualified, I'm glad to say that you want to pull up your socks now already and learn hard, so I suppose you've been doing it. It's very rewarding, learning or being inquisitive, going back the next day, where you're doing to follow up on those patients, what happened, etc. That's very important. Okay, I think we've heard quite a lot. We've learned about maybe expanding the curriculum. Also is something we've really thought of to give you more time to, for instance, have more pediatric experience, psychiatry experience, maternal experience, or your maternal health experience, as well as one thing that I was looking at is the sites. It was very interesting to me that at certain sites, there's very limited training in certain cases. And it's not the fault of the site. Please don't get me wrong. And it's not the fault that you don't want to do that, because what is the type of patients you're seeing at the site is what you're going to be trained in. So these things are things we must think about. Definitely a 4-year. I think the course is very jam-packed. It's very intense. There needs to be more time to learn, to practice skills, and to get the skills set into you. We are talking about guidance. We know about the personal identity, which we've spoken about, all the different names. But if you require more guidance, how should we be doing it with the new curriculum? And this will be taken all to other fields and areas as well. But, there were also a lot of good things that came out of here that have been identified, work that has been done that we just have to put together. So I'm going to, as in closing, before I give my total final remarks, is I'm going to ask each panelist in the order in which we actually, or maybe we should just do it in reverse order. Will you still remember where you were? Okay, we can do it in reverse order. To provide recommendations for the future. So just briefly. I think you've actually provided yours.
Yeah.
You may just reiterate it because they loved it.
As I say, they are teaching us well. I do think a little more guidance, maybe with regards to, for example, instead of saying, you don't understand this topic, go look it up, maybe providing, it happens, maybe providing specific websites. You don't need to give us the direct page, we can search, but maybe just some good websites that we can go into. Give us, that's what we mean by guidance.
Okay.
Maybe a little more skills lab time. Just small things like that, I think would make a huge difference with our confidence.
Yeah, no, for sure. I totally agree with that. As I said, you know, maybe with the four-year program, working all of this in is really going to be, and that will provide you more guidance because we can stretch it out a little bit, have longer time periods on things and allow for that. Thank you very much.
Thank you. So I'm here, Sanele, I think can I use this platform, right? Cool. I'm representing the Professional Association for Clinical Associates in South Africa. And currently there's a lot of exciting things that are happening. We're creating a website. We are planning an annual general meeting, which is where we conglomerate, that's the English. But basically we meet up and then we vote for new board members. So I'd like to encourage the students that are here, Uguti, after this session, let's meet up because we're currently forming a planning committee that's going to assist us with the annual general meeting. And based on that recommendation is awareness campaigns, like go out there, tell people about yourself. Thank you.
Thank you very much.
My recommendation is that I'm opening my doors for a round table conversation in how we can plan on influencing policy. There is officially policy reviews now, and I think we would benefit from having the relevant stakeholders influencing how the policy shift is going to go. Thank you.
Thank you for that. Yes, I think that's needed, sorely needed.
So I have been responsible over the last 5 years for leading a program that's increased our number of doctors that have graduated in South Africa by a significant number. And we need an honest discussion around to what extent certain interventions have brought about improvement in primary healthcare related outcomes. Because for the numbers of doctors that we are producing and the type of doctors we are producing for whether they're going to actually be working in community-related primary healthcare initiatives for the improvement of health outcomes, we have to ask ourselves honest questions around whether we are, in fact, now, even for our efforts, moving away from a hospice-centric system. And in my view, to speak clearly, Zuki, the answer is no. And I ask, therefore, that we have a real conversation between the key stakeholders. Yes, of course, Department of Health being such a vital stakeholder, but honest, collaborative conversations with clinical associates, with family medicine, with nursing about what we can do in the primary healthcare space, because we're not getting it right and we need to, and we have time.
Thank you.
Yeah, I think we are from a centuries-long history in healthcare of hierarchy, status, and power. And the clinical associates are doing well, but they are in a context and a system that's governed by status and power. So although the clinical associates, and I mean my experience in the middle of COVID, we employed 100 clinical associates to save mining companies from disaster. And the way they worked is just exceptional. Just after that, for us to be sacked, because we are not important enough. So my point is, those of us in positions of power, that includes myself as a family physician, a head of department, departments, MECs, etc. We need to take responsibility to create the space and the protection of the profession and the justice so that they can develop. We can leave them to fight for themselves for another 50 years, or we can step up like the Deputy Dean to say, this is not fun and games. We are not just patching up a little program here. There is a profession that's got a strong place in primary care, and that place no other profession can fill. And remember that role of association, coordination, and integration, which is the most important gap in our healthcare. But those of us in power, stand up, talk and do. Don't wait for something else.
Yes, Prof. Sameli, I'm going to cut. Sameli, don't worry, I'm going to cut that piece. I'm just going to summarize. Sure, what a way to finish this panel discussion. Absolutely fantastic. So my last words is to say that in conclusion, extending the duration of the clinical associate studies to 4 years and having them return to the communities as educators and healthcare providers can transform the healthcare landscape. It not only elevates the quality of care, but also addresses healthcare disparities and empowers communities to take charge of their health. We know how healthcare is changing. We've got to help our patients there, identify illnesses and treat them earlier there before it's too late and before they come to the hospitals and it's all overcrowded. That is just not on. As we map the future of healthcare, let us recognize the potential and the crucial role that clinical associates can play in leading the way. Thank you. I would lastly like to thank the panelists for their insight and which they have given us, the thoughts that we can take forward and definitely will discuss going forward. Thank you, everyone.
We have something for all of you.
I'm going to stand at the back. Are you close enough? Can we get... Yeah, we can do it now. Oh, she was coming out so too close. Yeah.
Now we're close to ending. We're very close to ending. I'm now going to invite Prof. Tivani Mashamba Thompson to come. She is our Deputy Dean as well. I think what we are excited about is that she is a mother of research in this university. Like Prof. Dean was saying when we started with this program, he said there is an MSc which has been approved and that MSc is going to benefit clinical associates quite a lot. It was approved yesterday. I wasn't even aware. We made an application earlier this year, and we have heard that it has been approved. And Prof was in the forefront of that. So it was approved at a Senate level. That's the highest level at university. Eh? So now I'm just going to invite Prof to please give us the closing remarks. I'm not sure if we're going to give 1 minute to the MSc if she needs to. She's fine. Okay, thanks. Yeah, thanks.
Maybe recognize very quickly those that sent messages online.
Yes, yeah. So we have been joined also by people online, and there were many comments. Unfortunately, because we are pressed for time, there are buses which are leaving. We can't take questions. There were many recommendations from online, but we can't accommodate them because of time. So I'm just now going to I would like to thank them for being with us. I've been told that it was more than 70 who joined online, and we're very excited about that. Thank you.
Thank you very much. Thank you very much. Thank you. So, MEC, I've just dropped my pen. So I just wanted to recognize you, MEC, and also our HOD of Gauteng Health, the acting HOD, Mr. Arnold Donald, Mr. Dr. Arnold. Yes, Dr. Arnold, yes. And also all the hospital CEOs and Prof. Steenkamp, and also all the esteemed, guests, ladies and gentlemen, everybody, students, colleagues. I just wanted to greet you before we can do the final remark. Before I even say anything, I also had a recommendation for all the students. We have also introduced an undergraduate research methods course that is totally free, and it's offered during after hours, and I want to see more of you enrolling on that, and we're also going to have speed dating with the dean and researchers with you guys, so you can get more and more exposed to research. So please enroll onto that one. That is in addition to the MSc degree that we mentioned earlier. So as we draw to the conclusion, and this was very much an enlightening special event that is being held on Physician Assistant or Clinician Associate Day, International Clinician Associate Day, and hosted by the Family Medicine Department, celebrating clinical associates and their impacts on our health system. So I'd like to express my profound gratitude to each and every one of you who made it to join us today and to celebrate this day with I think it's a very first in UP, maybe very first in South Africa or the world, yes. So we like to make history. So our time together, colleagues, our time together has been nothing short of exceptional. So I've learned quite a lot today, and the wealth of knowledge and expertise that was shared today. I was listening a lot with a lot of interest, because I'm a medical scientist and I don't know a lot about clinical associate. So I have no doubt that what we've all learned today will make a lasting impact on the future of our healthcare in South Africa and beyond. So also, throughout the course of the symposium, we have delved into the latest advancement in this profession, and I've been listening to that, and in the community health research space. So it was nice for me to also see a systematic review presented here, and I hope a lot of you do know that we've also established an evidence synthesis and translation research group that is assisting anyone and everyone who wants to conduct systematic reviews of high quality to be published in the similar journals that you published in. And we've just published in a Lancet this week. So you will see us in the social media soon. So yes, we've engaged in very inspiring discussion led by our our Deputy Dean of Teaching and Learning, and we exhausted a lot of innovative ideas and fostered connections. I already know who I'm going to connect with today, and I hope we'll continue, to flourish long-term relationships and collaborations beyond this. So, and I think it's clear that we're all, collectively dedicated to the pursuit of excellence and in this healthcare space. And it's been very evident to me today, and the passion that was shown by all the speakers and the commitment that was also displayed. And, most of the distinguished speakers that were speaking here, I could see they're all very passionate about the topic, and I could see everyone is engaged and participating in some way, even if it's just to look. Looking is participating. Yeah, so we were also highly honored by the presence of our Gauteng MEC of Health, and we really now want to give you a card, MEC. So, and I really liked your topic, which is, sketching the framework for clinical association. And this is a clear demonstration of the shared commitment that you have with us to fuel our drive to overcome the challenges that you've had presented today and to push the boundaries on what is possible and in this field of clinical associates. So I really want to thank everyone. I can't take up the whole day in thanking you. So, and I know I'm standing in between you and the rush hour. So I'm not really being very good by talking too much. So thank you very much, and have a lovely weekend and drive safely.